From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
I'm Dr. Kristin Walter, Associate Editor at JAMA and a pulmonary critical care physician. I'm joined today by Dr. Nancy Rigotti, who is Director of the Tobacco Research and Treatment Center at Massachusetts General Hospital and is a professor at Harvard Medical School in Boston, Massachusetts. We will be discussing the article that Dr. Rigotti and her colleagues wrote entitled Treatment of Tobacco Smoking, a Review, which was published in the February 8th, 2022 issue of JAMA. Thank you for joining us, Dr. Rigotti.
Thanks. Glad to be here.
So just to start with a global perspective, can you discuss the prevalence of cigarette smoking worldwide and the magnitude of the health consequences of tobacco use globally?
Well, worldwide, over 1 billion people smoke, and 80% of them now live in low and middle income countries rather than high income countries like the United States. In terms of health consequences, it's estimated that over 7 million deaths a year are due to tobacco worldwide, and that number is increasing.
And in terms of the U.S., how many people currently smoke cigarettes and what percentage of adults are current smokers?
In the United States, 34 million adults currently smoke every day or some days, and that's about 14% of the adult population.
And can you discuss some risk factors that have been associated with higher rates of smoking in the U.S.?
What we know is that smoking is more prevalent in people with lower incomes, less education, people with other substance use disorders, people with comorbid psychiatric diagnoses like anxiety or depression, people living with HIV, people in the LGBTQ communities, and members of certain ethnic groups, especially Native American individuals.
And can you discuss the main harms caused by tobacco use and describe the most common diseases associated with cigarette smoking?
So cigarette smoking kills people with 3 different types of conditions primarily. The first is cancer. About a third of the deaths due to smoking are due to cancer, and that's primarily lung cancer, but also cancer at many other sites. About a third of the deaths are due to cardiovascular disease, heart attacks, and strokes and others. And then about 21% of the deaths are due to chronic respiratory illnesses.
And how does cigarette smoking affect an individual's longevity or their mortality?
On average, a person who smokes regularly has about a 1 in 2 chance of dying of a tobacco-related illness. Also, on average, from population studies, what we know is that smoking reduces life expectancy by about 10 years.
So that leads to the next question, which is how does successful smoking cessation affect an individual's prognosis in terms of development of tobacco-related diseases and in terms of mortality?
Well, smokers who quit clearly benefit, no matter how long they've smoked or, quite frankly, how ill they are at the time that they do quit smoking. What we know overall is that the risk of the serious diseases related to smoking goes down even after the first diagnosis of a clinical disease. And we also know that on average, smokers who quit gain up to a decade of life expectancy, gain most if they quit early in life, especially before the age of 40. But even smokers who quit after the age of 65 or after they've had, say, a heart attack or the beginning diagnosis of COPD still live longer by quitting smoking.
Yeah, I have seen patients in clinic who are in their 80s and they say, why should I quit now? And, one of the things I said was, if you continue down this road, there's a likelihood that you may end up on long-term oxygen and have limitation in your daily activities. So I think it really is important that we counsel all smokers, no matter what their age is, to quit. Approximately what percent of smokers in the U.S. want to quit smoking? And what is the typical course of quit attempts for a smoker?
Well, nearly 70% of smokers will tell us in population surveys that they don't want to be smokers. They wish that they could quit. We know that about half of current smokers will say that in the last year they tried to quit smoking. They made a quit attempt, which we define as having gone at least 24 hours without smoking because you're on purpose trying to quit. But we know that most of those quit attempts will not be successful for a long time. They may be successful for a few days, a few weeks, and even a few months. but any single quit attempt is not likely to be successful because quitting smoking is a challenge. On the other hand, we know that about 60% of people in the United States who have ever smoked have now quit smoking. So the majority of people who keep trying to quit will eventually succeed.
And your review cited an article from 2018 that described approximately 55% of smokers reporting smoking cessation attempts within the year, but only 7.5% remaining abstinent for a year. Why do you think the success rate is so low for these smokers?
Well, one reason is that very few of those people who are trying to quit used any treatment to help them succeed when they quit. They tended to rely instead on willpower because of the misconception that many people and many smokers have that it's a matter of willpower rather than a chronic illness that needs help and needs treatment. So, stopping smoking is a challenge because it requires an individual to succeed at two tasks. First, they need to break a nicotine dependence, a physical dependence on nicotine. And then second, they also need to change a long-standing ingrained behavior that they've used to cope with challenges throughout their lives. And so it really requires succeeding at both of those things at the same time. And we have treatments that can help people, but they're way underused. And one of the great opportunities that clinicians have is that we can connect patients to these treatments. We know that advice from clinicians gets patients to try to quit. Where we tend to fall down a little bit is that we don't connect the patients that we've motivated to make a quit attempt to effective treatments. And that's really the challenge for physicians and other clinicians across the United States today.
And talking about clinicians, what are some optimal teaching moments that might help patients in the smoking cessation process?
Well, anytime someone comes down with an illness that is smoking related is a teachable moment, is what we call it sometimes. It takes the knowledge that people have that smoking is bad for people, but maybe not for me, and brings it home and makes it salient. And so the classic example is having a heart attack. It used to be said that almost one of the best ways to quit smoking was to have and survive a heart attack because so many patients simply decided at that point that they weren't going to smoke anymore. Hospitalization is another opportunity because you can't smoke in hospitals these days. And so if you're admitted to the hospital, you have several days of enforced non smoking. But another way of looking at that is that it's the beginning of a quit attempt that you can continue after you get home. Tobacco related illnesses in family and close friends can also be kind of a wake up call that gets smokers to quit.
That's very interesting. And when clinicians are talking with patients, one recommended communication tool is the three-step model, which involves asking, advising, and assisting. Can you outline those steps for us?
Sure. So the asking is pretty simple. It's just asking every patient about whether they're smoking, although the most effective way to do so is not to say, "Are you a smoker?" because many intermittent smokers don't think of themselves as smokers. They don't identify with that identity. And so it's better to ask, "Do you ever use tobacco products or do you ever smoke tobacco?" Then the second is the advice. Clearly, advising someone to quit as soon as possible is the message. But it's important to focus on the positives and to connect the reasons that you're giving this advice to, if possible, something the patient cares about, like the reason they came in to see you today because of some symptoms or illness. Or you can use other factors that aren't even health related. You can use that you won't spend as much money. So you never know what might make a difference. The last step is the assist step. And that really is two things. It's offering treatment to all smokers. We don't these days talk so much about asking people if they're ready to quit, but rather to just plain offering treatment to every smoker and seeing if they're interested. And then it's not only offering the treatment, but connecting them to treatment. And the two types of treatment that we're talking about are pharmacotherapy or behavioral support. And what we know is that those two types of treatment are each effective by themselves, but they're more effective when combined together. And that's the sort of standard of care that we should be offering to our patients these days.
And what is the best way for clinicians to assess the level of nicotine dependence that an individual patient has?
Nicotine dependence can be quickly assessed with just two questions. First is the number of cigarettes smoked per day, and the second is how long it is after you wake up in the morning that you have your first cigarette. We know that nicotine has a short half-life, and so that the more addicted you are, the more likely you are to need to reach for a cigarette first thing in the morning because you've gone into withdrawal overnight. So people who smoke within 30 minutes of awakening are thought to be more addicted than those who don't smoke for 30 minutes. There are patients who will smoke at night when they wake up because they are so addicted.
Like in the middle of the night, you're saying?
Yeah, there are patients who will say that they will smoke in the middle of the night if they wake up and they're feeling that they're in withdrawal and they can't go back to sleep.
Yeah, so moving on to treatment, you mentioned behavioral and pharmacotherapy. There were two recent U.S. government-sponsored reviews, the 2020 Surgeon General's report on smoking cessation and the 2021 U.S. Preventive Services Task Force recommendation statement on smoking cessation. And they concluded that both behavioral and pharmacotherapy treatments are safe and effective, and that they're more effective when used together. So starting with the 3 FDA-approved medications for smoking cessation, can you discuss nicotine replacement therapy and how effective it is in increasing smoking cessation rates when compared to placebo?
Sure. Generally, what we think about for pharmacotherapy is that pharmacotherapy roughly doubles the quit rate compared to placebo or no treatment. For nicotine replacement, the meta analyses indicate most recently that it increases the quit rate by about 55%, which is still a clinically important amount.
And in terms of the products to use, there is an additive benefit of using a long acting nicotine product, such as a patch, in combination with short acting nicotine products like gum for smoking cessation. Can you discuss that?
Sure. Nicotine replacement products are not all the same. They have different bioavailabilities, which means how rapidly the nicotine gets to the bloodstream and to the brain, basically, and how long it stays. And so the patch is one category, which is a long acting product, but it takes a couple of hours before it really reaches peak levels. On the other hand, the other forms of nicotine replacement, the gum, the lozenge, the inhaler, and the nasal spray, are all short acting, but they reach peak much more rapidly. And so the concept of combination nicotine replacement therapy is to use the patch as your base product to have a constant level of nicotine to prevent withdrawal symptoms all day long. But when and if nicotine withdrawal symptoms break through during the day, then you use the short acting form, one of the forms, as needed to sort of cover breakthrough cravings. We know that this is very well tolerated. People don't overdose, and it's been shown to be more effective to use nicotine replacement in a combination fashion than to use single products alone. So, one thing that many of our patients don't know is they will say to us, "Oh, I've tried nicotine replacement, it didn't work." What they probably tried was a single product at a time. And so, one thing that you can come back with is to say, well, we know better ways to use nicotine replacement than we used to. And I have some new ideas that might be helpful. That might be a way to encourage a smoker to try nicotine replacement again.
And for a hypothetical patient who's on a nicotine patch, how often can they be chewing gum or using another short acting nicotine product?
Well, when you're using the gum by itself, you use it as needed, but often once an hour or so. But it's really should be dependent on the patient's nicotine withdrawal symptoms, their irritability, their cravings. Patients don't overdose on nicotine. And in fact, most smokers have been quite accustomed their whole life to keeping their nicotine levels in a therapeutic level, not too high, not too low. And so they kind of know how to do this. They've been doing it for many years. And so they kind of naturally will have just enough, but not too much.
Interesting. And moving to the next FDA approved drug for smoking cessation, varenicline, can you describe its method of action and how effective it is for smoking cessation compared with either placebo or no treatment?
Sure. So varenicline is, I sometimes call it our designer drug. It's a partial agonist at the alpha 4 beta 2 subtype of the nicotine acetylcholine receptors. And this particular subtype of the receptor is very rich in the midbrain where the reward systems are. And the idea of this is that by taking it as an agonist, it blocks some of the nicotine withdrawal symptoms. But as an antagonist, if someone smokes while they're on the drug, they don't get the same reward from smoking because the drug is in place and blocks the nicotine from being rewarding. So it has this kind of hypothetical dual action. The meta-analyses tell us that it's roughly a little more than twice as effective as placebo when used by smokers to help them quit.
And in the past, there were some concerns that it may have some neuropsychiatric effects, such as increasing risk of depression, suicidality, or aggression, as well as some adverse cardiovascular effects. But in 2016, the FDA removed the warning label for this drug. What information led the FDA to withdraw that product label warning?
So after the FDA signaled in 2009 that there might be some concerns based on case reports, eventually they required the manufacturers of both bupropion and varenicline to do essentially the largest smoking cessation trial that's ever been done. It was called the EAGLES trial. And it was a randomized controlled trial that compared directly head-to-head varenicline, bupropion, the nicotine patch, and placebo in over 8,000 smokers, half of whom had no psychiatric comorbidities and half of whom had mild to moderate psychiatric comorbidities, largely anxiety and depression. And the trial was done to look not at efficacy, but at side effect rates. And the primary endpoint was a group of neuropsychiatric symptoms that were used to define a worrisome adverse effect. And what they found in the trial is that there was no difference across drugs and placebo in the rate of neuropsychiatric side effects in the trial. They did find that patients who had psychiatric comorbidities were more likely to have this endpoint than those who didn't. But even in those with the endpoint, the rates were well below 10%. And so this was really about as definitive a trial as you could imagine. And based on that information, along with other data that had been collected over the past several years, the FDA took off the black box warning in 2016. Unfortunately, a lot of doctors don't know about it, and an awful lot of patients don't know about it. And varenicline still, unfortunately, has kind of a bad name out on the street. And a lot of people are afraid of using it. But the data are quite clear that it's quite effective and quite safe. And there have been studies using it even in patients with schizophrenia successfully.
Interesting. Bupropion is the third FDA-approved drug for smoking cessation. Can you describe how this drug works and how successful it is as a single agent for smoking cessation?
Sure. So bupropion is an atypical antidepressant. It's not an SSRI. It increases dopamine release in the mesolimbic pathways in the brain, and those are the pathways associated with reward. And we think that that's basically how it's effective for smoking cessation. In the meta-analyses, increases quit rates by about 65%. Again, nearly doubling. And that's our understanding of how it works.
So now that we've discussed the three FDA-approved smoking cessation drugs, can you talk about how clinicians should decide which medication to start a patient on and what specific patient factors might be considered when making that decision?
Well, first of all, we always think about efficacy. And we know that all three of the classes of medicines are effective. And so they're all good opportunities. And we can talk in a moment about how you might distinguish among the three. But certainly they all work and they're all really quite safe. And so I think that it's important to allow patients to have some say in what recommendations are made, but perhaps explaining the different opportunities, the different types, and let the patient choose. Another factor that can be important is what, if any, experience the patient has had before with any of these medicines. Many of the smokers that we see these days have tried one or more of these medications, and getting some details about what happened. For example, if one of the medications was completely not tolerated, then that's probably not something you'd be using again. On the other hand, sometimes people have had a good experience, been able to quit for a while, or maybe close to quit, cut down a lot, but not quite get to quitting. Well, maybe that drug could be used again, maybe in combination with something else or with better behavioral support. So it may be a launching pad for your next quit attempt. So it's a matter of really kind of taking a history of previous quit attempts and experience, as well as thinking about chronic diseases. Other than that, bupropion is not recommended in patients who have a seizure disorder or a predisposition to seizures. Varenicline is very well tolerated, but is contraindicated in patients with severe chronic kidney insufficiency, chronic renal insufficiency. Nicotine replacement is really pretty safe. It's an over-the-counter drug, and so essentially, unless you have an allergy to it, it's pretty safe to be used by pretty much every smoker.
And how long are these smoking cessation treatments typically prescribed?
The FDA licenses these medicines for 3 months or 12 weeks, generally. Most of them have been shown to be perhaps a bit more effective if you continue for 6 months, especially if someone has been quit for 3 months. They're often more likely to stay quit if they continue a little bit longer, because smoking is a chronic relapsing disorder, and it just takes a while for someone to become a more kind of constant ex-smoker. But they're not drugs of abuse, and so I really encourage patients to use them as long as they need, even if they need to use them for more than 3 or 6 months, if they feel that they need to continue on them in order to stay off cigarettes. And I encourage them to use it until they feel that they will stay non-smoking without the medication.
And you mentioned earlier the EAGLES trial, which was a randomized double-blind clinical trial that compared the 3 FDA-approved medications as well as placebo in a large population of smokers. Can you describe the findings of this study?
Well, we already talked about the findings in terms of the adverse effects, but in terms of the efficacy of the medications, this trial was, perhaps the most definitive trial, allowing us to compare head to head 3 different drugs, nicotine replacement, bupropion, and varenicline, against placebo. What we found is that all 3 of the medicines were more effective than placebo, but that varenicline was more effective than bupropion or the nicotine patch, and that was statistically significant. Specifically, the continuous quit rates at 6 months were about 22% for varenicline, about 16% for bupropion, about 16% for the patch, and about 10% for the placebo group.
Typically, pharmacotherapy is prescribed for individuals who've decided they are ready to quit. Can you describe the use of pharmacotherapy for people who aren't quite ready to stop in the very near future, but plan to reduce their cigarette intake before a quit attempt in the next several months?
Yes, specialists in this field are beginning to use medications more liberally and to consider using them even for patients who aren't ready to quit right away. There's evidence both for nicotine replacement and for varenicline being used in this way, used for patients who are wanting to cut down, not ready to set a quit date yet, and it can be effective in that way. There's a very nice trial that was done with varenicline where they took people who were not ready to set a quit date in the next month, but wanted to quit in the next 3 months, and they wanted to cut down. And what they found is that by starting varenicline, people already were starting to quit, even though they weren't planning to quit. And then they stayed quit over the 6 months. And then everyone at the beginning got varenicline or placebo for 3 months. And at 3 months already, the people who weren't planning to quit, many more of them had quit smoking. And at 6 months, that difference was maintained. So it suggested that varenicline, even given earlier than somebody's ready to say, yes, I'm going to quit smoking in the next week or 2 weeks, it can still be effective. So it's something to offer to patients who aren't ready to set a quit date. I often would say, well, why don't you try it now a little bit, and let's just see if you can cut down with this and how you tolerate it, and come back in a month and let's see how that's going, and maybe this will turn out to be the drug for you. Same could be said for nicotine replacement products as well.
Now I'd like to just shift to electronic cigarettes. What is known about the use of e-cigarettes for smoking cessation?
We know that a number of smokers have tried e-cigarettes. as a way to cut down or quit. In fact, most people who are using e-cigarettes are people who are trying to reduce the health harms of smoking. What do we know about how effective and safe they are is really an important question. In clinical trials so far, they have shown, according to a recent meta-analysis, that e-cigarettes were more effective than the nicotine patch and more effective than behavioral support only in smokers who were trying to quit and use these products, and that they were safe for up to 2 years' time. That being said, the limitation is that there's not a lot of evidence. There aren't a lot of trials for a variety of reasons. And then also, there aren't a lot of trials on the most recent e-cigarette products because the products have evolved so quickly. So there's a limitation on the amount of evidence we have, which has sort of limited the recommendations that many bodies will make, such as the U.S. Preventive Services Task Force. But the evidence that we have suggests that they can be effective in helping patients to quit. Now, we also know that outside of the setting of clinical trials, a lot of smokers are trying to use these products to help them cut down and quit. And you might say, well, what evidence do we have from just observational data kind of in the community or in the real world? And there we see that patients who completely switch over to e-cigarettes are more likely to quit than those who don't. But patients who mix, who continue to smoke cigarettes and intermittently smoke e-cigarettes, the use of e-cigarettes in that way does not look like it's a particularly effective way to quit smoking. So these days, I think physicians and clinicians will be seeing patients who come to them already on e-cigarettes. And there, I think the important message is to find out whether someone is still smoking and to deliver a very clear message that it's important to completely switch over to not smoke any cigarettes in order to really reap the benefits of reducing harm and ultimately quitting smoking.
And what are some potential concerns about the health effects of e-cigarettes? Because they certainly don't contain the same carcinogenic compounds that are found in combustible cigarettes.
Right. E-cigarettes differ from regular cigarettes in that no tobacco is burned. They really are nicotine delivery devices where the nicotine in a liquid is heated up into an aerosol that is then inhaled. But there's no smoke, there's no combustion, and none of the products of combustion, which is what causes most of the health harms of smoking, are part of these cigarettes. And so they should be much safer. And we know now that the concentrations, as you mentioned, of many of the harmful constituents of cigarette smoke are much, much lower in e-cigarettes than in conventional cigarettes. And that said, they should be much safer. Our understanding is that they will be safer than continuing to smoke. And so the concern has been that, well, they're new products. They could have other health effects that we don't know about. And they're not likely to be completely safe because they do expose users to some products that could potentially be harmful. So what's most important to think about is that compared to continuing to smoke, these products are almost certainly much, much less harmful. The uncertainty has been, well, how much, if any, harms do they have and over long periods of time? These products have been on the market, available in the US for only about 10 years, and they haven't been around long enough for us to know what, if any, long-term harms they might have. So far, we haven't seen any in terms of increasing rates of cardiovascular disease, pulmonary disease, or cancers. And it seems unlikely that we will compared to continuing to smoke. But that's been the concern, the certain uncertainty of these products.
And last question about e-cigarettes. Has the FDA formally evaluated them as a smoking cessation aid?
That's a really good question, and it's confusing. The FDA has not formally assessed e-cigarette for a medicinal claim, a health claim, meaning that they help people quit smoking. No manufacturers even put them up to the FDA to ask the FDA to make that decision. But the FDA also regulates tobacco products in a different division, the Center for Tobacco Products, which is quite different from the medications side of the FDA. And so e-cigarettes are currently considered tobacco products. They're regulated as these consumer products. And the Center for Tobacco Products is in the process of evaluating e-cigarettes and needs to decide whether or not that they should be remaining on the market. They're in the process of doing that. They've had millions of applications of e-cigarettes products that are asking for this allowance to remain on the market. And they've been going through them. They've excluded a number of them. They have accepted one product basically in a couple of different forms as a tobacco product that can remain on the market. That's not to say that they have blessed it as being helpful. Their decision means that they've decided that the net public health benefit of the product is greater than the net public health harm of the product. That's very different than the standard we use for medications, which is for an individual person, is there a benefit over a harm? So it's complicated.
That's very interesting. Yeah, it's going to be interesting to see how that will evolve over time. I'd like to briefly talk about behavioral support programs. Can you discuss some common behavioral interventions for smoking cessation and how effective they are?
Sure, there are a wide range of behavioral programs, but basically the components are usually some component to try to motivate someone to help them decide to make a quit attempt. And then once someone has decided to make a quit attempt, the behavioral programs help them to be successful by helping them to figure out how to reduce cravings, how to increase their belief that they can be successful. That we call that self-efficacy, which is an important component of success, how to avoid situations where they're going to be tempted to smoke. So it's very simple behavior change strategies, and they can be delivered in person. They can be delivered effectively by phone, by text messaging, by web-based programs, by apps. So there's a variety of ways to get this message across, and that gives you a sense of the variety of the programs that are out there.
So as we wrap up, I want to ask you just two more questions. What do you see as important future directions in the fight against cigarette smoking?
One future direction that people are talking about is something that's called the end game, which is the idea that we will aim to not just control tobacco use, but actually to wipe it out. Now, it's unlikely that we will ever wipe it out or that we will actually ever ban cigarettes in this country. But the goal is to have a series of both public health and treatment approaches that can help to reduce smoking prevalence to, say, less than 5%. And there are a variety of different policy efforts that have been discussed as to do this. None of them are happening in the United States, but we can continue doing what we're doing, which we're already doing a good job of, which are the policy approaches of smoke-free environments, of raising taxes on cigarettes.
Increasing the legal age of purchase to age 21, is that one possibility?
Increasing the age to 21, yeah.
And then my last question is there anything else about smoking or the treatment of tobacco smoking that you'd like to mention to our JAMA audience?
Sure. What I'd like to point out that people often don't think about is that tobacco smoking is actually a key driver of the large disparities in health that we see across the U.S. population. That more vulnerable patients are more likely to smoke and less likely to have access to treatment and less likely to quit. And so that by making smoking cessation treatment more available to everyone, and for physicians, by focusing on tobacco as one of the things that they're trying to change when working with patients, we can begin to be reducing disparities in health effects across the population.
That was Dr. Nancy Rigotti, who is director of the Tobacco Research and Treatment Center at Massachusetts General Hospital and a professor at Harvard Medical School. Thank you so much for sharing your thoughts with us about this interesting and important topic.
Thank you. My pleasure.
This is Dr. Kristin Walter. This episode was produced by Shelley Steffens at the JAMA Network. The audio team here also includes Daniel Morrow, Jesse McQuarters, Lisa Harden, Audrey Foreman, and Mary Lynn Frikoluk. Dr. Robert Golub is the JAMA Executive Deputy Editor. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.